Okay, this is the digestive system, and this is the first of 2 chapters that are going to be on the next test. So, we'll start off with digestion as a whole, and the digestive system is also called the alimentary canal or the gastrointestinal tract, and its function is to digest and absorb food. So I call the digestive tract the disassembly line. And you can see on this picture here, these are all parts of the digestive tract. So you have the mouth, which is the oral cavity, the tongue, and then you have a series of glands, and you go into the pharynx, esophagus, down to the stomach, small intestine, large intestine, rectum, and anus. The accessory glands, gallbladder, liver, Pancreas, all add secretions, as well as the salivary glands, but those are all the parts, okay? So we're going to be going through all of them. That's just an overview of the tube itself that starts with the mouth, ends with the anus, and the accessory glands, and we're going to be going over everything, so stay with me, and listening to this audio lecture will help give you some clues for what's going to be on the test, because I'm not going to do a review. You will have a review sheet, but if you go through the audio lecture with me, you will have everything you need. So there are 4 processes involved in digestion. The first one is ingestion. That is taking food in to the digestive tract, usually by way of the mouth. And then you have what's called digestion, and there's chemical and mechanical digestion on your notes. It's divided into 2, and I put them both together here. Chemical is the addition of enzymes by the secretions of the digestive tract, which help to break down all the food substances you take in. Mechanical, there's 3 things that are going to occur that are called mechanical digestion, and these processes break down the food to increase surface area. So chewing in the mouth is the first thing that helps to break up the food. You add saliva to it, and what this does is it kind of softens the food and makes it into a ball that's called the bolus. You can swallow that, and that goes down the stomach. Then when you get to the stomach, you have the churning of the stomach and the addition of gastric secretions that adds more fluid to the food, and it makes it into a thin, like a creamy white paste that's called chyme, C-H-Y-M-E. And then the third type is segmentation that occurs in the small intestine, and that's localized movement back and forth. It's different from peristalsis. This is segmentation, and it helps to add fluids from the small intestine and make the food that's going through the chyme from the stomach, make it even thinner so that you can absorb those little building blocks that end up coming from the food you eat. You break everything down into their individual parts. So mechanical digestion is chewing in the mouth, and then churning of the stomach, and then segmentation in the small intestine. Chemical is using the enzymes that are found in the fluids that are secreted into the GI tract. Absorption. You're going to be able to absorb nutrients into the bloodstream primarily, and most of your absorption is going to take place in the small intestine. That's where most of it occurs. Defecation is elimination of indigestible solid waste. So those are the 4 essential processes that occur in digestion. Now this is a look at the tube and the layers of the tube. So you have the mucosa, which is the inner layer, and remember that most of the GI tract, keep this in mind, is lined with simple columnar epithelium. Simple columnar epithelium. That's what most of the GI tract is lined by. And then you have the submucosa, which underlies that mucosa. And you do have glands in here. Remember we talked about things like Peyer's patches and GALT, gut-associated lymphoid tissue, that helps protect the lining. And then you have 2 layers of muscle, and you have a circular layer and a longitudinal layer, and then that's the muscularis externa, and then the outermost layer is the serosa, and most of the time it's just connective tissue. So mucosa, submucosa, muscularis externa, and serosa. There's your mucosa-associated lymphoid tissue right there. Right there. Okay, so just elaborating a little bit on what we talked about here. Mucosa lines the lumen, and there are 3 functions. It secretes a lot of mucus, also those digestive enzymes that go into chemical digestion, and we're going to talk about some of the hormones that are released in the digestive process. These are localized hormones that are involved specifically in digestion, absorbs the end products of digestion, and protects against infectious disease. That's what we refer to as the BALT. There's 3 layers: epithelium, lamina propria, muscularis, mucosa. Don't worry about those so much. Submucosa, okay, we talked about that. Muscularis externa. This is responsible for those movements that we talked about. Segmentation, localized agitation back and forth. Peristalsis is different because it's unilateral. It's moving the food or propelling the contents of the digestive tract from one place to another. They usually refer to it as like a wave-like contraction. I would remember that. Peristalsis, wave-like contraction, and propelling food from one location to another. 2 layers of muscle. Some areas of the muscle are thickened in the sphincters, like you have the gastroesophageal sphincter, and that's between the end of the esophagus and the beginning of the stomach. And then you have the pyloric sphincter, that's at the terminal portion of the stomach to the beginning of the small intestine, so that's what we're talking about there. And there's the myenteric nerve plexus between the 2 layers that's actually controlled by the autonomic nervous system, vagus nerve in particular, to cause movements of the GI tract. There's the serosa, and it is in many places, and especially in the abdominal cavity, associated with the visceral peritoneum. Remember that the peritoneum is that double layer of membrane that surrounds organs that are moving. And the stomach moves, the intestines move, and the visceral layer is the part that attaches to the organs. And remember, the parietal layer attaches to the inner wall of the abdominal cavity. So in many places, the serosa is just that, that innermost layer of the serous membrane. Areolar connective tissue covers it in most organs, so it's a little bit thicker than just one layer of simple squamous epithelium. When you get into the thoracic cavity where the esophagus is, you don't have a serous membrane there. So the esophagus has a fibrous adventitia, and that's fibrous connective tissue that attaches it to the posterior surface of the trachea. Because remember, they are attached. Now, the retroperitoneal organs, those are the ones that are behind this visceral peritoneum. Those have an adventitia on the back that anchors them to the thoracic cavity wall and a serous membrane on the anterior surface. So, the enteric nervous system that controls activities in the GI tract, you have these visceral fibers, so it's connected to the central nervous system, and you also have enteric plexuses that are inside of the tube itself. These right here are associated with the vagus nerve, okay? That is a parasympathetic effect to stimulate the digestive tract to move and undergo peristalsis and cause the stomach to churn and all that. This is the gut brain, which is kind of unusual, but actually the GI tract, by changes in pH, that can stimulate the tract to be activated. For instance, the esophagus has a pH of about 8. The stomach has a pH of about 2 to 3. And then when you get to the small intestine from the stomach, the pH goes back to about 8 again. So independent of nerve connection, the pH change could actually cause secretions and cause stimulation in different parts of the tube. So if you have food coming from the esophagus that's 8 that goes into the stomach that drops to 2 to 3, that food that's coming down with a pH of about 8 could stimulate the gut brain to produce gastric secretions. And then again, from the stomach, pH 2 to 3, going to the small intestine, which is 8, that gut brain can be stimulated to do that too. So changes in pH is what the gut brain is referring to. So here's a look at that mesentery we were talking about, the peritoneum. Okay, so the peritoneum is that layer of serous membrane. There's your parietal peritoneum, which lines the inner surface of the abdominal wall. And there's the visceral that surrounds the tube. This is just kind of a cartoon picture. But in some locations, you actually have a double layer. And this double layer is called a mesentery. So a mesentery is actually a double layer of serous membrane that also has nerve fibers running through it. It has small arteries and veins, and it nourishes the tube. It has innervation to the tube and helps to anchor parts of the digestive tract in place. Because when you get to the abdominal cavity, you have a lot of intestine all kind of piled up in one area. And it's not just laying in there like a pile of spaghetti, it's organized. And the mesentery helps to organize it and keep it together. So you have a dorsal mesentery, which anchors the tube to the posterior abdominal wall. And then you see there's a ventral mesentery. And so look here, it's tethered to the liver, and then it's kind of another piece right here that anchors it to the anterior abdominal wall. So you want to remember that a mesentery is a double layer of serous membrane, and it helps to hold different parts of the abdominal cavity in place, or abdominal contents in place, rather, sorry. So we'll talk about the oral cavity first. Let's start with the mouth. And I'm not really going to hold you responsible for too many of the structures because I think Lauren will be going over those. But you do have some tonsils visible here. These are the palatine tonsils, and the opening to the oropharynx, the tongue. And that's really what all I'm going to say about it, because I'm not going to ask you anything on the test about that. There's the tongue, showing you again tonsils, papillae. I'm going to skip over that. But we'll talk a little bit about teeth. Now you have two sets of teeth. You have what are called deciduous teeth, and those are your baby teeth. Deciduous means that these are shed. So these teeth start erupting about 6 months, and in about 2 years you have the full set of 20. And then at about 5, 6, or 7 you start losing these, and you get your permanent teeth, your second set of teeth. And you have 28 teeth here, and then you have your wisdom teeth, which you have 4 of those. So you end up with a total of 32 teeth. Now, some people never get their wisdom teeth. Some people, they just never come in, or some people have to have them taken out. But usually, you have them all by about 27 to 25 years of age. This is the structure of a tooth, and the enamel is the covering of the tooth, and it's actually the hardest substance in the body. It's very, very dense, very tough. Underlying that is the dentin, and the dentin is maintained by little cells called odontoblasts. So the odontoblasts are kind of similar to the osteoblasts we talked about in bone, and those cells are living and they maintain the dentin. Their blood supply comes from the pulp cavity, because in the pulp cavity here you have blood vessels, and you also have a nerve. So you get feeling through the teeth as well as a blood supply. And that blood supply and nerve come in through an opening at the bottom of the tooth called the apical foramen. The tooth is anchored to the jawbone by the periodontal ligament, so that holds it in place. 3 parts of the tooth: the crown, the neck is the constricted area that goes into the gum, and then you have the root. So make sure you know enamel is the hardest substance in the body. The dentin is the living part of the tooth that has the odontoblasts that maintain it. And the pulp cavity is where the blood supply and the nerves are found that actually give feeling to the tooth. So salivary glands. We're going to talk about saliva. You have some functions of saliva. And saliva cleanses the mouth. It dissolves food chemicals for taste, and it moistens the food, and it compacts the food into a bolus, which is a little ball that you swallow. And also, saliva adds an enzyme called amylase that begins the breakdown of starch. So saliva is 97 to 99% water. It's slightly acidic. These are the electrolytes that you find, quite a few different electrolytes: sodium, potassium, chloride ions, phosphate, bicarb. Salivary amylase, remember, which is for the breakdown of starch. Carbohydrate digestion begins with amylase. Keep that in mind. A little bit of lingual lipase, mucin, mucus, a metabolic waste, urea, uric acid, and these different substances here are for protection against microorganisms: the lysozyme, immunoglobulin A, defensins, and cyanide. So there's where your salivary glands are. You have 3 different pairs of salivary glands. The parotid gland is the only one that really releases saliva into the upper part of the mouth. So I'd remember what the glands are named and where they release their secretions. So the parotid gland is it's actually on top of the masseter muscle, and it releases saliva by a duct. These are exocrine glands, so they have ducts into the upper part of the mouth. And then you have the sublingual and submandibular glands that actually release saliva into the bottom of the mouth. So from the mouth, food goes into the pharynx. Now, there are a couple terms on page 4 of the notes. It mentions the word chewing as mastication. So the word mastication is chewing, and then the word deglutition is swallowing. So deglutition is swallowing. Food passes from the mouth into the oropharynx and then down into the laryngopharynx. Now, the laryngopharynx allows the passage of food, fluids, and air. And at that point, remember, it switches and air goes into the larynx, and then food goes behind into the esophagus. Now, the lining is stratified squamous epithelium, and you have mucus-producing glands. And the skeletal muscle layers, remember, there's 2 layers. You have your circular and your longitudinal layer. So the esophagus is a flat muscular tube from the laryngopharynx to the stomach. So it's about 25 to 30 centimeters long, which is about 10 inches, and it travels through the mediastinum and pierces the diaphragm at what's called the esophageal hiatus. That's the opening in the diaphragm. And it joins the stomach at the cardiac orifice. And then you have a sphincter, which is called the gastroesophageal or cardiac sphincter, that surrounds the cardiac orifice, and it prevents stomach gases from getting into the esophagus. Because remember earlier I said the esophagus has a pH of 8, the stomach 2 to 3. So if that sphincter wasn't there, you would really burn the outer layer of the esophagus. You'd burn it tremendously and cause a lot of pain, and people do have problems with that. Okay, so those are the main features of the esophagus. So homeostatic imbalance is heartburn, and that's where stomach acid regurgitates into the esophagus, and it can happen with excessive food, drink, extreme obesity, pregnancy, running, also with a hiatal hernia, which is a structural abnormality where part of the stomach protrudes above the diaphragm, and that can lead to esophagitis, esophageal ulcers, and eventually esophageal cancer if it's not treated. So this is looking at that process of swallowing, deglutition. So during the buccal phase, that's where you are swallowing and you're initiating it. That's voluntary. So the buccal phase of swallowing is voluntary, but there are 22 pairs of muscles that are involved in swallowing. So once you get past the buccal phase and you get into the pharynx, at that point then, now it's involuntary, and that's called the pharyngeal esophageal phase. And this is controlled by muscles of the esophagus, and by constriction of the circular muscles and shortening of the longitudinal muscles, food moves into the stomach. Now it takes about 4 to 6 minutes. 4 to 6 seconds rather, 4 to 6 seconds once you initiate the buccal phase to get food from the mouth down into the stomach. Okay, now we're going to talk about the stomach. The stomach actually has 4 parts. You have what's called the cardia region here, and that's the part that's actually the beginning, and the uppermost part is where you have that the gastroesophageal, the sphincter there. The dome part at the top is called the fundus. That's the rounded part at the top, and sometimes this is the part that actually protrudes through and causes your hiatal hernia. Then you have what's called the body here. This is the main region, largest region of the stomach. And then the terminal part is the pylorus. So I would remember those 4 regions: the cardiac region, the fundus region, the body, and the pyloric region. Now there's a couple of curvatures. You have the greater curvature here, which is actually going to be attached to a mesentery. I'm going to show you a picture of that in a minute. Remember, a mesentery is what helps hold parts of the GI tract in place. So the stomach has 2. One's associated with the greater curvature, and the other one's associated with this lesser curvature. The termination point of the stomach is the pyloric sphincter, and when the stomach's empty, it's folded into these little folds that are called rugae. And the stomach, when it's empty, only holds about 50 milliliters in its collapsed position. But when it's full, it can hold up to 1 gallon of food and fluid. So it can really expand. So this is showing you the ommenta of the stomach. Now the ommenta is the specific name of the mesentery associated with the stomach. So we talked about mesenteries, but the ones that are associated with the stomach are called ommenta. So you have the lesser omentum, which tethers the stomach to the liver, and then the greater omentum, which goes from the greater curvature, attaches the stomach to the intestine, as you see there. Now, the stomach has a series of pits. If you look at the inner lining of the stomach, it's got these holes. These are called gastric pits. Now, the gastric pits go way down into the lining of the stomach, and they have a series of glands. And these glands are very, very important because the glands are going to produce the secretions that help digest the food as it's coming into the stomach. So remember, you swallow a bolus, it goes into the stomach, and then by adding some secretions and the churning, the mechanical action, which is churning of the stomach, and the addition of the secretions that come from these glands, you're going to make this bolus even thinner and make it into a very thin paste that we call chyme, C-H-Y-M-E. So that's one of the stomach's job is to make that food that's entering a lot thinner. The blood supply to the stomach, you have the gastric artery and vein, then on your notes, page 6 talks a little bit about some of the circulations, and I'm going to skip that. I'll talk to you about that when we get to the liver. So, the gastric pits have a series of glands. And the glands, this one here, the parietal gland, that gland produces hydrochloric acid and intrinsic factor. Now, intrinsic factor is needed for the absorption of B12. So that's really important. The absorption of B12 is from intrinsic factor. Now, hydrochloric acid is needed for the activation of a substance produced by the chief cells. Now, the chief cells produce something called pepsinogen. And pepsinogen is a protein enzyme. So remember what we said earlier when we said carbohydrate digestion begins in the mouth with the presence of amylase? Well, protein digestion begins in the stomach with the presence of pepsin. So the chief cells produce the inactive form pepsinogen, and hydrochloric acid helps to convert that into the active form, which is pepsin. So pepsin is a protein enzyme. And because the pH of the stomach is 2 to 3, do you remember us talking about proteins and that they have a three-dimensional shape? And that three-dimensional shape is really important in their functioning. And that you can denature a protein by raising the temperature too high or dropping the pH too low. So the stomach having a pH of 2 to 3, that denatures your proteins, they fall apart, and that exposes more surface area so the pepsin can break them up. So hydrochloric acid has a dual function, denaturing the proteins, making them fall apart so that you expose more surface area, and activating pepsinogen into pepsin. So parietal cells secrete intrinsic factor and hydrochloric acid, chief cells pepsinogen, which is converted into pepsin. And mucous neck cells, remember, this is some of the harshest conditions that you'll find in the body is in the interior of the stomach. The pH is 2 to 3. I mean, we're talking about really serious erosion could occur if you didn't protect this lining. So you have an awful lot of mucus, and you also have a lot of bicarb secreted to help protect and neutralize the acid that you find in the stomach, so it won't damage the lining. So this is a look at a gastric ulcer, because if you have a problem with that lining not being protected, then you can have something called a stomach ulcer. Now, they found out that most people have a bacteria in their stomach called Helicobacter pylori. And Helicobacter pylori normally is not a problem for most people, but if it becomes activated, then it can start to erode away the stomach lining. So if you have a problem with stomach acid and you're not sure what the cause is, if it is H. pylori that's causing your stomach problems, you don't want to take an antacid, because that will make it more, that will make the environment a lot more conducive to activity by H. pylori. So you want to make sure you know what your problems are before you really medicate and treat yourself. So this is a look at how hydrochloric acid is secreted. So we've seen this little equation before when we're in the respiratory system, but it's kind of the same thing. By mixing carbon dioxide with water, you wind up with carbonic acid, and then you have bicarb, and the bicarb splits. A bicarb, your H ion, goes out here. So that's where your H ion comes from in exchange for potassium, and H is part of that hydrochloric acid. And then by co-transport, the bicarb goes out, chloride ions come in, and then the chloride goes out here, and the hydrogen ion and the chloride ion coming together make the hydrochloric acid. So it's all caused by the splitting of that carbonic acid. Not that you have to know this, I'm just showing you how it occurs, and we did talk about this a little bit before. We saw where this was used somewhere else. So homeostatic imbalance of problems with the stomach, vomiting, emesis caused by extreme stretching, sometimes intestinal irritants, bacterial toxins, excessive alcohol, spicy foods, certain drugs, so chemicals, sensory impulses. What happens is you have this thoracic expansion and abdominal contraction. It creates a pressure difference, dilating the esophagus, and you get this tachycardia, rapid heart rate, profuse salivation and sweating. And then when the abdominal contractions and rising thoracic pressure opens up the gastroesophageal sphincter, and vomiting occurs. So, and we've all been there at one point or another. But excessive vomiting can be dangerous because it can result in dehydration and severe problems with electrolyte and acid-base imbalances, and can cause alkalosis. So this diagram looks very busy, but I'm just going to minimize it by talking about these three phases just really quickly. I'm not really going to test you. You can spend time on this if you want to, but just to kind of make it as a simplify is what we're going to do. Okay, so the first thing is there are three phases: the cephalic phase, gastric phase, and intestinal phase. And this is the release of gastrin. So gastrin is something that's produced by the glands at the bottom of the gastric glands. These are called enteroendocrine cells. And if you go back to page 7, they're on there at the top of the page. And the enteroendocrine cells produce gastrin. Now, gastrin is important because it causes the secretion of the other glands, okay, so of your parietal cells, your chief cells. So gastrin gets everything going. And if you look at page 7, histamine is there too, and histamine causes the production of hydrochloric acid. So that's why that's important, because hydrochloric acid, remember, is needed for the activation of pepsinogen and to denature the protein so that you expose more surface area. Endorphins are produced by the enteroendocrine cells too, because it's pleasurable to eat. That's why serotonin makes you feel good. And cholecystokinin and somatostatin I'm going to leave for a later discussion in the chapter. So, cephalic phase, that occurs, that's when you think about food. So if you're over somebody's house and you smell the food cooking, you can see it, and you can smell the bacon and all that, that's the cephalic phase. Gastric phase is when the food hits the stomach, okay? So when the food's in the stomach, that's when you're going to get your maximum amount of gastric secretion. And then the intestinal phase is when the food's moving from the stomach into the intestines, slowing things down so that you can start the intestinal operations and slow down the stomach activities. So usually, if everything's working normal, then you think about the food, you eat the food, hits the stomach, and then it goes into the intestines. And there are some things that are inhibitory. Sometimes you have emotional problems going on, depression, you're upset. You have other things going on. You may not think about eating, or you may just not have the desire to eat. So those are involved with inhibitory events, and then natural inhibitory events occur as food is moving from the stomach into the intestines. So I like to say cephalic phase is the wake-up call. Gets the stomach rumbling, you're thinking about food. And then the gastric phase is full steam ahead, because there's food there, and you're actually starting the stomach churning and secreting a lot of gastrin and those secretions to help to break down the proteins and start the formation of chyme from the bolus that you swallowed. And then the intestinal phase is put on the brakes, slow things down so you can slow down the activity in the stomach and move the food into the intestines. So that's basically what's happening here. And remember, the stomach is going to be where you produce and form chyme, which is a lot thinner than the bolus that you swallow. So actually, the food is going to move from the stomach into the small intestine at a very, very slow rate. It's only about 3 milliliters, little squirts, 3 milliliters per minute, and just gradually moving food from the stomach into the intestines. So we're going to take a little side trip here, and we're going to talk about the liver. Now, the liver is the largest gland in the body. It weighs about 3 pounds, and there are 4 lobes. Pay attention to that. 4 lobes: the right lobe, left lobe, caudate, and quadrate. From the top, you can see the right lobe of the liver is the largest. Left is here. The lobes are separated by the falciform ligament, and the round ligament is in the anterior surface. And underneath the right lobe, you can see the gallbladder is protruding out there. This is the inferior surface. There's the gallbladder. There's your caudate lobe. There's the quadrate lobe. And then you also have this area that's called the porta hepatis. That's where your circulations come and go from the liver. Now, the liver is composed of very small structures that are called liver lobules. Now, the liver lobules are hexagon-shaped, and they are the structural and functional units of the liver. Okay, so I want you to remember that. You have the hexagonal-shaped liver lobules. Now, these are kind of hexagon, so they have 6 sides. And in the center, you have a central vein. So I want you to remember that. There's a central vein in the middle. And some of these things may not be on your notes, so make sure you write them in. So the central vein is in the middle, and these are all of your little lobules. Okay, this is a picture of the lobule, and you'll see that it also has these little triads. And the triads are made up of a branch of the hepatic arteriole and the hepatic portal vein, and also you have a bile duct. Now I want to tell you something about this hepatic portal vein. Now, what you have coming from the stomach and coming from the small intestine and coming from the spleen, you have 3 veins. So you have the splenic vein, you have the gastric vein, and you have the superior mesenteric vein coming from the small intestine. And remember, most of your absorption takes place in the small intestine. Some of your absorption happens in the stomach. There's some things that actually get absorbed right through the stomach lining, like alcohol and some medications. The spleen is another one, and these all converge into what's called the hepatic portal vein. Now, the hepatic portal vein takes all the venous flow from those 3 organs, the spleen, the stomach, and the small intestine, and brings it to the liver. So what I want you to be aware of is that everything that gets absorbed through the stomach and the intestine goes to the liver first. So the liver gets nutrients first from the body. So that's a hepatic portal vein. And then you also have a branch of the hepatic arteriole. So these 2, that hepatic portal vein and the hepatic arteriole, drain into these sinusoids. And see these tan cells? Those are hepatocytes. Those are the functional cells of the liver. And the sinusoids is where you have a mixing of venous blood and arterial blood. But that's okay, because what you're doing is you're supplying nutrients to the liver, and they're absorbing those nutrients. They're also detoxifying things that are absorbed through the stomach and the intestines, help to break down some of the medications that you ingest. And then they drain into the central vein, and then the central vein is actually going to take that circulation back to the hepatic vein, exit out the bottom of the liver, and go back to the venous circulation. So that's the triad. Now the bile duct actually goes in the opposite direction, because bile is produced by the hepatocytes. Now, if you remember that the hepatocytes take red blood cells out of circulation, okay? And those red blood cells are broken down. And the hemoglobin gets broken down into bilirubin. And bilirubin goes into bile. So bile is produced by the liver by the breakdown of red blood cells. And that bile is going to exit out, and it's actually going to be stored in the gallbladder. So you want to remember the structure of the liver lobule. It's a functional and structural unit of the liver. There's a central vein in the middle, and it has these triads, a branch of the hepatic portal vein, the hepatic artery, and the bile duct. Okay? Now, there's the liver. There are the bile ducts, right and left hepatic ducts of the liver. They come together and they make a common bile duct. This is called the cystic duct. The cystic duct takes the bile and it's stored here in the gallbladder. That's a storage tank for bile. And then they come down to the bile duct. Bile duct, here's the sphincter. And bile, I want you to remember, is a fat emulsifier. It helps to break down fat. That's its job. And it's combined here with a duct from the pancreas. Now the pancreas produces your major source of lipase. Now lipase is to break down fat. So if you have fat that's in a water-based secretion, because so far we've been talking about saliva, and you have gastric secretions from the stomach. They're all water-based, okay? Fat is not a water-soluble substance. So when you have it in a water-based fluid, it's going to just sit there as a blob. So you need something to break down the fat, and that's what bile does. Bile is a fat emulsifier. It breaks it down to expose more surface area. So if you're producing lipase to break down, that's the enzyme that breaks down fat from the pancreas, you want to release that enzyme in the same area where your fat emulsifier is, so you can maximize emulsification and maximize the effects of that enzyme. So it's perfectly designed. Okay, you got the emulsifier there, and then you have the enzyme coming out at the same place. And this is called the hepatopancreatic ampulla, which is a swelling, and the sphincter. And the swelling is caused by the two passageways coming together, the bile duct and the duct from the pancreas. Pretty cool, huh? And this is the beginning of the small intestine. This is the duodenum, all right? So pancreatic juice. Interestingly enough, you produce a lot of secretions in the GI tract. I mean, a lot of water-based secretions. So you actually produce about 1 liter to 1.5 liters of saliva a day. The gastric glands produce 2 to 3 liters of water-based fluid, and then the pancreas produces another 1 liter to 1.5 liters per day of this watery alkaline solution. Because remember, the chyme that's coming from the stomach, you remember what the pH is? 2 to 3. And we have to neutralize it when we get to the duodenum because that's got a pH of 8. So pancreas helps because it produces this watery alkaline solution that helps to neutralize the chyme that's very acidic coming off the stomach. The major electrolyte is bicarb. Bicarb is a base, so it helps to neutralize the acid. And the enzymes are amylase, so you produce some more amylase that breaks down carbs, right, starch. Lipases to break down fat. Nucleases, nucleic acids, because a lot of what you eat is cells, and cells have nuclei, and the nucleus has nucleic acids, chromosomes, so you have to break those down too, something you don't really think about. And they're secreted in active form, but many of them do require ions or bile, because you need bile to expose more surface area for the lipase to work. Proteases usually are secreted in inactive form. And the reason why I put that there is you can't have proteases active inside the cells because then they start digesting the cells. So you usually want to put them in a place where they're safe to do their job. Okay? So that's pancreatic, that's the pancreatic secretion. Okay, so activation of your enzymes. So you do have some enzymes that are produced from the pancreas, and here's just a few of them. You have trypsin, and then you have chymotrypsin, carboxypeptidase, and it has to really do with the structure of the proteins themselves. And these enzymes work on these protein chains, and they attack it from different directions. And it's all due to the biochemical structure of the proteins, and I'm not really going to go into it. It's just that you need many different types of enzymes to work at the protein from different parts of the protein. So it works like scissors, cutting it up in different places and breaking the proteins down into their individual amino acids. So that's just a few of them there. So the regulation of pancreatic secretion, there's something called cholecystokinin. I know that's a really big word, but it is a very important enzyme because it actually causes the secretion of a very enzyme-rich pancreatic juice by the acini. That's the name of the cells that produce these gastric secretions, these pancreatic secretions that are involved in digestion. Remember that the pancreas has other areas. We talked about the islets of Langerhans, where you have the alpha and beta cells that produce insulin and glucagon. So they're there too, but they're in a different place. Those are different cells. This is the acinar cells that produce the secretions that go into the small intestine. Now, secretin is another hormone that if you have a very acidic chyme coming off the stomach, Secretin will cause the production of a bicarb-rich pancreatic juice to cause a greater increase in pH if you have a lot of acid coming from the stomach. So secretin is very important to help to raise that pH. Vagal stimulation is important too, but it's that gut-brain, the change in pH is really important, and these hormones of making sure that the changes are made as you're going from a very acidic environment to a more basic environment. So this is showing you how CCK and secretin work. So chyme enters the duodenum, and it causes the cells of the duodenum to release cholecystokinin and secretin. So cholecystokinin is the red dots, secretin is the yellow dots. They go into the bloodstream. CCK causes the secretion of an enzyme-rich pancreatic juice, and secretin causes more bicarb to be produced to neutralize that chyme coming from the stomach. Bile salts and secretin transported by the bloodstream stimulate the liver to produce bile more rapidly. CCK causes the gallbladder, these are other things that CCK does, causes the gallbladder to contract, hepatopancreatic sphincter to relax, bile enters the duodenum, and during the cephalic phase and gastric phases, when you're thinking of food and food's entering the stomach, the vagus nerve stimulates the gallbladder to contract weakly. So you want to remember basically that CCK is important for the production of the enzymes that are found in the pancreas and to release bile. So it causes the gallbladder to contract and to release pancreatic secretions. It relaxes that sphincter that goes into the duodenum, and secretin, bicarb-rich pancreatic secretion to neutralize the acid coming off the stomach. So now we're going to go back to the intestine. So we talked about the liver, the gallbladder, the pancreas. Those are accessory organs. And now we're going to the intestine. And the intestine actually is 19 to 23 feet long in a cadaver. But due to muscle tone, it's only about 7 feet long in a living person. So I thought that was really interesting. And it runs from the pyloric sphincter, the end of the stomach, to the ileocecal valve that brings you back into, at that point, you're going into the large intestine, or the colon. Now, the small intestine has 3 parts, okay? The jejunum, the duodenum, the jejunum, and the ileum. And the duodenum is the first part. Duodene means 12 each. And actually, the duodenum is about a foot in length, so it's about 12 inches long. And the other parts make up the other 6 feet of the small intestine. So the jejunum is about 40%, that's about 2.5 feet. And the ileum is 60% of the rest that's left, and that's about 3.5 feet. So about 7 feet in length. And then these are the parts of the large intestine. And we'll talk about the large intestine when we get there. So the small intestine has some modifications. Because remember we said most of your absorption occurs in the small intestine. And the modifications are things that help increase surface area and to slow down the chyme that's coming from the stomach so that you can maximize absorption. So you have 3 things, and this is at the top of page 11 on the notes. You have what's called the plicae circularis. Those are the circular folds that you see here, so the inner surface has more of a threaded appearance. So instead of the chyme just shooting right through the small intestine when peristalsis occurs, it wraps around these folds. So it goes around and around and around, and it kind of slows it down and brings it in close contact with the surface. And then you have the villi, which are the macroscopic inner folds of the small intestinal wall. And then you have these microscopic folds, which are called the microvilli. So the plicae circularis, the villi, and the microvilli, those are all of the structures that are involved in increasing surface area and maximizing absorption. So you want to make sure that you're familiar with those. So that's looking at a villi, and then they've taken a little piece out here so you can see the microvilli, and they also call that the brush border. And you can see here we've talked about lacteals before, and lacteals are those structures in the from the lymphatic system that are involved with absorbing fat. So fat gets absorbed through the lacteals in the villi. There's your mucosa-associated lymphoid tissue. It seems like we never can get away from that. And the intestine itself actually produces an alkaline solution and about 1 to 2 liters of enzyme-poor, mostly water, solution that helps with the absorption of the end products of digestion. Now, the histology of the wall, Peyer's patches protect especially distal part against bacteria. Those are lymphatic structures. And then in the duodenum, you have Brunner's glands that secrete alkaline mucus to neutralize acidic chyme. So you do have additional structures to help to neutralize the acid coming off the stomach, and those are Brunner's glands. Okay, so motility of the small intestine. Remember in the beginning of the chapter, I said that segmentation is mechanical digestion. It's the most common motion of the small intestine. It's initiated by pacemaker cells in the lining, and it's more of an agitation, localized pinching back and forth to increase surface area so that you can absorb more nutrients, and gradually moving the contents toward the ileocecal valve. Peristalsis is a wave-like contraction that moves the remnants of the digested substances, bacteria, debris, move to the large intestine. And to get from the duodenum to the ileum, it takes about 2 hours. So 2 hours the small intestine, and actually the stomach 4 to 6 hours. Okay, so another little detour here in talking about how different food substances are absorbed, the enzymes that are involved. So we'll walk through this quickly, but carbohydrates comes first. And your first source of enzyme is salivary amylase. So you start a little bit of digestion there. Then you have pancreatic amylase, and so the pancreas produces more carbohydrate enzyme that helps to break these more complex carbohydrates down into very small subunits. When you get into the small intestine, then you have your disaccharides at that point, and so you have enzymes. You have lactase, you have maltase, you have sucrase to help to break these 3 disaccharides you see here, lactose, maltose, and sucrose, down into galactose, glucose, and fructose. And those are your end products of carbohydrate digestion, and they can be absorbed into the lining of the intestine. And remember, like we said earlier, where do they go? They're transported to the liver by the hepatic portal vein, because everything that comes off of the digestive tract goes to the liver first, just about. Now we have proteins, and our first enzyme involved with protein digestion is pepsin in the stomach. And remember, you have to have HCl to activate it. Then you have pancreatic enzymes. Remember trypsin, chymotrypsin, carboxypeptidase. We said we need a lot of different proteases because these proteins are long chains and they get chopped up, and they're attacked from different directions. Different types of enzymes are involved with breaking apart these chains. When you get to the intestine, now you have more. You have aminopeptidase, carboxypeptidase, and dipeptidase, and eventually you're going to break down these long amino acid chains into their individual amino acids, and then, see here, transported to the liver by the hepatic portal vein. So that's the source of your enzymes and what happens to the amino acids. That's the end product of this process. Now fat's a little bit different, because you have some lipase from the mouth, some lipase from the stomach, but you know what? Nothing much is going to happen until you get to a point where you have bile. So when you have bile, which is the fat emulsifier, that's produced by the liver, stored in the gallbladder. It's released with the lipase that comes from the pancreas. That's where most of your fat digestion is going to occur. So the pancreas is where it all happens. And you're going to break those fats apart. Now, most of your fats are triglycerides, and I want you to keep this in mind. Triglycerides are broken down into fatty acids and glycerol. And then they're absorbed into the lining of the intestine. And the intestine is going to take those and repackage those up and put a little coating of protein on them, and they're going to go into the lacteals. So most of them go into the lacteals, absorbed there. But some are transported to the liver by the hepatic portal vein. So here's your chylomicrons that enter the lacteals of the villi and are transported to the systemic circulation by the lymph. So a lot of the fats go right to the fat cells by that absorption through the lacteals, but some go to the liver by way of the hepatic portal circulation. Okay, back to the tube. Okay, so we're going to finish up with the large intestine. So the large intestine has a few parts. So I want you to focus on looking at the parts with me, and then I'm going to back up and I'm going to talk a little bit about water. On page 12, it talks about all the sources of enzymes. A very interesting point here. So here you have the beginning. This is your ileocecal valve. The terminal part of the small intestine is the ileum. The beginning of the large intestine is this dead end pouch. It's called the cecum. And then you have the ascending colon, and then it bends sharply here. This is the right colic or hepatic flexure in the area of the liver. Transverse colon, the left colic, splenic flexure because it's in the area of the spleen. Descending colon, sigmoid colon, which is an S-shaped part. Then you go to the rectum and the anus, okay? Now, back up to page 12 where it says water. The digestive tract receives about 9 liters of water per day. 0.7 liters in food, 1.6 liters in drink, 6.7 liters in the GI secretions. That comes from saliva, 1 to 1.5 liters, gastric juice 2 to 3, bile about 1/2 liter, pancreatic juice another liter to 1.5 liters, intestinal juice 1 to 2 liters, and out of all this 8 liters of this, it's absorbed by the small intestine, and that leaves 0.8 liters by the large intestine, leaving only 0.2 liters voided in the daily fecal output. So just about everything out of that 8 liters is absorbed back into the circulation. Okay, so that leaves about a little bit more than 1/2 liter of indigestible food residue per day, and the intestine is going to reduce it to about 150 milliliters of feces by absorbing water. So the main thing that the intestine does is absorb water and salts and eliminating the feces by defecation. So, and here's an interesting thing. It's actually smaller than the small intestine. Small intestine is about 7 feet in length. Large intestine is about 5. So large intestine is also called the colon. Okay, these are modifications of the large intestine. You have what are called tenea coli. Those are 3 bands of longitudinal muscle that when they are contracted, they fold the colon up into little pockets, and that's called a haustrum. Plural is haustra. So these little pocket-like sacs are caused by the muscle tone of the tenea coli. And then you have things that are called epiploic appendages. Now the epiploic appendages are fat-filled pouches of peritoneum, so fat-filled pockets of mesentery that hang off the surface of the large intestine. Nobody knows what their function is really, but I say they're just like Christmas decorations. They just hang off the surface of the large intestine and it looks pretty. So that's my take on those. And then we'll go to the purpose of the bacterial flora. Now, the bacterial flora enters from the small intestine or the anus, and it colonizes the colon, and this flora synthesizes B-complex vitamins and vitamin K. And it also metabolizes some host-derived molecules, mucin, heparin, hyaluronic acid, ferments indigestible carbohydrates, and that fermentation causes flatus. And flatus are those irritating gases and acids, about 500 milliliters per day. So that is what the bacterial flora does. So homeostatic imbalance of the large intestine. Now the large intestine, food stays there for 12 to 24 hours. It takes a long, long time. And but during that journey, sometimes if you have problems with movement through the colon, like a low fiber diet, it can cause the colon to be narrowed, and it can result in very strong contractions that increase the pressure on the walls and result in diverticula. These are herniations of the mucosa. Diverticulosis, commonly in the sigmoid colon, affects about half of the people greater than 70 years of age. So very, very important to have colonoscopies after the age of 50, maybe earlier if you have a family history of colon cancer. Colon cancer is the second most common cause of cancer, and diverticulitis is inflamed diverticula, and nothing to play around with because these may rupture and leak into the peritoneal cavity and could be life-threatening. So something to pay attention to. This is looking at the defecation reflex. Now, motility of the large intestine. Haustral contractions occur every 30 minutes. These are slow segmenting movements that move contents of the colon, and haustra contract as they are stimulated by distension, because remember, when you stretch a tube, it wants to contract. So mass movement, stronger contractions, occur 1 to 3 times a day and last about 15 minutes. And usually you feel these. And they are often triggered by food entering the stomach. That's the gastrocolic reflex. Now this reflex is defected in irritable bowel syndrome. And people with irritable bowel syndrome, when you fill the stomach, it makes them have massive contractions of the colon and makes them feel like, you know, they have to go right away, and usually 15-20 minutes after they eat, they have severe diarrhea. So that's irritable bowel syndrome. But in most normal people, filling the stomach after a long fast, like after you sleep at night and wake up in the morning, mass movements occur, especially in the transverse to the sigmoid colon, often within an hour after breakfast. So defecation, distension of the rectal walls caused by feces, okay? So it stretches the colon, there's smooth muscle, and then it wants to contract. That's the reflex. And this is going to relax the internal anal sphincter. Now, the internal anal sphincter is not voluntary. The external one is the one you can control, and that's the external anal sphincter. So once that hits that external sphincter, then defecation occurs. And sometimes it's aided by Valsalva's maneuver, in which breath holding and contraction of the abdominal muscles increases the pressure, compresses the rectum, and helps to eliminate the feces.